Now we'll go ahead with the troubleshooting unhappy patient, which is associated with retinal pathology. So, over to you, Dr. Sharat Hegde.
I thank AIS and Dr. Krishna Prasad Kudlu for giving this opportunity. So there is always a chance that few of the patients who undergo cataract surgery may be unhappy after the results. And finally, to find the cause of unhappiness, it will come to retina to see what it can be a condition is. Once the anterior segment, all the features are normal. So there are various conditions. Overall, any retinal condition can cause decreased vision, but majorly there can be two things. One, it can be subnormal vision, means even after the cataract surgery, the vision is not improved completely. It can be due to non-improvement of the vision, or the second thing is even after the cataract surgery, it immediately post-op the vision was good, but after a few days the vision started deteriorating. The another condition is floaters. The way the patient will be complaining, a mosquito-like thing is moving in front of my every day. All those things can also be complaining can be there. So there are like any conditions, most of the conditions which can affect the retina can have these conditions. And the most important conditions to cause non-improvement of the vision is especially any condition which can cause your macular thickening, like diabetic macular edema or cystoid macular edema can lead to this. Like foveal thinnings post CRVO or CRAO, all those conditions, and any optic nerve involvement also we can see. And the most common condition to cause decreased vision after the cataract surgery few days later is post-op CME. I'll just touch upon these few conditions. So this patient who had underwent a cataract surgery 6 weeks before, vision was good 6.6, and after 6 weeks he complains he has a blurring of vision, and the vision was around 6.18 and N8. And when we saw that clinical, if you see the fovea, it looks not very much difference, looks normal, but there will be some amount of elevation which can be seen clinically in 3D version in indirect ophthalmoscopy. And definitely OCT will show you the presence of cystoid macular edema. So this is a case of post-op cystoid macular edema, which usually we see 4 to 6 weeks after the cataract surgery. If the patient has any intra-op complications or history of previous uveitis and diabetes, these patients have a high risk of development of post-op CMS. Usually, most of the patients, they resolve by 3 months, but nowadays we won't wait till the 3 months to resolve slowly. We prefer to give steroids, especially I try to give posterior subtenon steroid injection for these patients. If it is not improving or if it is retracting, then I go with anti-VEGF or Ozurdex implant inside the eye. Some people also give diflupred eye drops also, which I said it improves better with that injection, with drops also. So this is the patient which I have given PST, and after the treatment, nicely the edema has resolved. The other most important condition nowadays has the diabetes is increasing, the diabetic macular edema. And cataract surgery has been shown that it is associated with the worsening of the diabetic macular edema after the cataract surgery. And there is approximately 22% of the patients can develop macular edema after their cataract surgery. So this is one of the post cataract surgery patients, maybe patient having a total cataract or the retina may not be visible. Post cataract surgery, when their vision is less, when we saw her retina, she had a large diabetic macular edema. This is a study done by UK group where they showed us after the cataract surgery, the chances of development of DME sharply increases, especially if the patient has moderate to severe NPDRs. And this is another study done by Chen et al., where they showed post cataract surgery there was a statistically significant increase in the central involving diabetic macular edema. So this is the one case where a patient underwent cataract surgery, and after 2 weeks we can able to see the development of macular edema in the eye. So usually in these cases, what I prefer, if the patient has any moderate to severe NPDR with no macular edema or there is extrafoveal edema, I prefer to give anti-VEGF along with the cataract surgery. Similarly, if the patient has diabetic macular edema, always we treat the macular edema, then go for a cataract surgery. And if the patient has significant cataract, then usually I prefer intraocular implant or anti-VEGF 2 weeks before the cataract surgery. And before doing a surgery, we do an OCT and see whether the edema is decreased. If it is decreased, we go ahead with the cataract surgery. And maybe sometimes the patient may have PDR retraction, which may be missed, and it may be a reason for subnormal vision. And another important point which can be missed easily is ERMs. And there is some certain studies which showed ERM per se may not increase after the cataract surgery, but the edema or thickness, macular thickness can increase following the cataract surgery in the case of ERMs. If the vision is very abnormal, less than 618, or the patient is very asymptomatic, very symptomatic, saying lot of photopsias and all, then we go for a ERM peel. Another important which can be missed out is vitreomacular traction. Clinically, if you see, it may look normal, but there will be enhanced red reflex. The foveal reflex will be dull. And when we do an OCT, we can able to see a large traction which can be there. And sometimes these vitreomacular traction can progress into the macular hole after the cataract surgery. This is one patient who came with 18 vision before the cataract surgery, and 2 weeks after the cataract surgery, she came with 636 with a near vision of N12. And you can able to see in 3 weeks there is a progression of vitreomacular traction into a macular hole. This happens because the PVD can increase after the cataract surgery, and that has led to the macular hole. Or the patient may have pre-existing macular hole before doing a cataract surgeries. And the most common nowadays is the age-related macular degeneration. It can be wet age-related macular degeneration or a dry age-related macular degeneration. Most of the times it will be diagnosed before doing a cataract surgery. If the cataract is very significant or the mature cataracts, it may be missed. I advise usually before doing any cataract surgery, please do a preoperative OCT so that even if it is missed clinically, we can pick it out in the OCT. So this is the one study which showed whether after doing a cataract surgery, this ARMD changes progresses. Some patient may ask, because of the cataract surgery, the dry AMD has converted into wet AMD. But many studies have shown there is no correlation of a cataract surgery along with the progression of ARMD changes. There can be certain vein occlusion and causing the foveal thinnings. And sometimes these tributary vein occlusions can be missed out. And when you see clinically, if it is very difficult to identify, our FA can show you the capillary occlusions, and it will help us to identify the cause of decreased vision. Chronic CSRs, and the most important thing is the drug histories. So it's most important to ask the previous drug histories, because in this case you can see there is a bullseye-like retinopathy, and it's something called as foveal reflex sign can be seen. This is due to the patient was taking HCQ tablets since many years, and this is the case of HCQ toxicity. And the dystrophies also can be there. The patient may not give a history of night blindness or any dystrophies, and they can have foveal thickening or thinning in these conditions. And if the retina is absolutely all right, then you should look on the optic now. The patient can have previous non-arthritic ischemic optic neuropathies or advanced glaucoma. The presence of opticociliary shunts over the disc may make you think the patient has old vein occlusions. Or there can be very rare conditions called white dot syndromes like azure and mutes and all, which can lead to decreased vision. This is the one case which is showing the optic disc pallor. And the most dreaded condition after the cataract surgery, nobody wants it, is post-op and offs. Acute, yes, everybody will get to know early, but in the chronic conditions, like the patient will come with recurrent redness after 3 weeks, 4 weeks. Once you decrease the steroids, the patient will tell, my vision is decreasing, my eyes is redness, I am not happy. So always keep in mind these pigments, whitish pigments which is sitting behind the IOLs can be a pigments or chronic end of maybe a condition. This is another picture showing the fungal which has grown in the bag and come into the anterior segment. These conditions are very tricky to manage. Sometimes we may need to explant the IOLs. Recurrent uveitis, yes, most patients may come with recurrent uveitis. Especially 1 in 400 patients can have recurrent uveitis, maybe because it is a sulcus placed IOL, or we see more commonly in a case patient who has diabetes, or patient is using any tamsulosin like tablets, or the patient has been used the pupillary hooks and all. Coming to just one few points on PVDs, if there is a recurrent floaters, make sure there is no lens fragment or there is no small fragments which is there sitting behind in the vitreous cavity. If it is a plain floaters, we can wait for a few time, or we can go for AG vitreolysis if it is more than 6 months, it is not resolving. But if you see a nucleus material, it's important to remove. Cortical material will decrease, but a nucleus material we may need to do vitrectomy to remove that. So take home message, the most important is to take the duration, how many days the vision is decreased, and the previous treatment. Complete evaluation including RFPD has to be checked. Preoperative OCT for all the patient help to detect the retinal problems. If a mature cataract, please do ultrasound B scan to rule out any underlying retinal condition. And if anything which is not able to recognize, referral to the retina specialist also becomes important. Thank you.
Thank you, Dr. Sharath, for a very important talk. But one important slide I could able to observe about the recurrent redness. Patient comes with a recurrent redness. We always sometimes we have to keep it in mind about the endophthalmitis caused by the P acne. So patient coming with this P acne endophthalmitis normally it mislead us. So how exactly we treat, whether IOL exchange has to be done immediately or can we wait for a long period, especially to treat this patient?
It's all depending on the condition, how much is the severity of the endophthalmitis and where this pigments are, where this organism is sitting. If it is very much sequestered within the bag, we can try something called as injecting the intravitreal antibiotics within the bag, and washing the bag sometimes can also help you to decrease the condition, or intravitreal antibiotics also can help. If these conditions are not resolving, then only we go for IOL explantation.
Yeah.
Dr. Sunil?
Yeah, P acne endophthalmitis has various grades. If it is a mild form, probably it responds only to topical steroids and oral steroids. If it is a moderate, probably you may have to do a removal of plaque as well as giving an in the bag vancomycin, or sometimes do an AG and give an intravitreal vancomycin. If it doesn't respond to that, if it is a severe form of P acne, you have to do a capsulectomy with the cutter using a pars plana approach or something. So it depends upon the severity of that. The other thing, whatever the well-covered topics, points, Sharat, I would like to add is, whenever you are seeing a mature cataract or something in the pathology, please try to highlight and look the fundus of the other eye also, because many of the retinal pathologies could be bilateral. Like AMD, you can see some druseness in the other eye or something which gives a clue that this patient may have some pathology in the other eye also. So we can't just ignore by the B scan in a mature cataract, nothing is there. If you see any pathology in the other eye, try to explain to the patient you may be having a similar thing in the other eye, and try to do OCT in most of the cases. Even if you find a slightest of the, it could be dull foveal hystix or a few hard exudates or whatever may be that, try to do this thing, and try to do a peripheral examination also. It is beyond this topic, because many of the times we look at the central fundus, we tend to neglect many of the lattices and other things and all. So any of the post-operative complications which can occur because of the, either because of the obscuration of vision by the cataract or improper examination of the fundus evaluation. Sharat, what is your pseudophakic CME protocol when you would like to inject and when you would like to use the drops?
So most of the times, if I see a pseudophakic CME, I go for the injections. I won't wait till it aggressive. If the macular thickness is more than 300 or more than 320, I go for the posterior subtenos injection. I give like a transeptal injection, like how you give the block. I give 1 cc of tricot in this area, which usually they resolve by 1 month. If it is less than 300 microns, I give diflupred also 2 to 3 times a day for 1 month, and definitely IOP has to be checked regularly. And if still it's not worsening, then I go do a FA to see really is it a post-op CME, or is it due to any other uveitis, or is there any other condition which is causing the macular edema. Based on that, I will think further the injection, whether I have to go for implant or the anti-VEGF.
A very valid point. See, don't be under the impression that posterior subtenos given always should be given in the posterior superior temporal quadrant, which many of may not be familiar with the techniques, and you may feel risk of globe perforation and other things. You can use a simple 26 gauge needle, give a peribulbar injection like that, like you give xylocaine, you can give that like that also. That is an alternative option, one thing. The other thing is, especially in diabetic macular edema associated with cataracts, please closely follow up the patients who have got a posterior capsular rent. Once the PC dehiscence occurs, invariably DME or diabetic macular edema progresses very fast because of the VEGF expression and the increased inflammation. So whenever there is an uneventful surgery in a diabetics, still can have an issue, but those who got a PC rent and other things in a diabetic patient needs to be closely monitored than the uneventful surgery patients.
Thank you.